10 years ago, we met over in a building right next door to where we are now on the engineering campus to meet with Victor Kaposha to talk about this idea of what has become NIATx. And I can remember us all kind of gathered around the table and sitting there listening to Victor. He was making his case to Dave and to those of us around the table. And after he left, I know we had a lot of discussions of, is this something we really want to do? Or do we just want to continue on the path that we're on? And as you know, we decided to do it. And I think what was a real surprise to me at that point in time was just how many agencies were interested in the process. We had over 300 applicants in the first round of Paths to Recovery. We had another couple of hundred in the second round of Paths to Recovery. And unfortunately, we could only fund about 25 of those agencies in both rounds. We were fortunate, though, as we look back, that we were able to get together with Fran Cotter and our partners at CSAT and bring that program together, that Paths to Recovery program that the Robert Wood Johnson Foundation had funded to bring and create NIATx. And we started off slow. We kind of did our own, PDSA change cycle around NIATx. We worked with one round of organizations first. We worked with a second one after that, and then things began to take off. But as I think back about those first couple rounds, one of the things that really sticks with me is the decision we made to form an active, open partnership with Dr. Dennis McCarty and his team at Oregon Health Sciences University. That relationship has continued 10 years into the future because it led us to several other grant initiatives, including recently, we finished up about 2 years ago, the NIATx 200 initiative, where we had recruited over 200 treatment agencies around the country in 5 states to be a part of this study. And what we learned from that is that coaching and participation in learning sessions seem to make a difference at improving some of our outcomes. And that coaching itself seemed to be the most cost-effective of those outcomes. But as I think back about where we've been along this journey, we started with addiction treatment agencies, but we've evolved so much further. We're doing work now in mental health, where we're helping counties and mental health agencies improve their processes of care to reduce readmissions or to just reduce the amount of time it takes to get in to see a psychiatrist. We had a grant called Advancing Recovery, and we have another second one now called the Medication Research Partnership. Both of those are as part of our work with Dennis McCarty, where we're trying to help substance abuse treatment providers do a better job of implementing medication-assisted treatment in their organizations. But our reach hasn't been limited just to behavioral health. We've worked with public health organizations. We've worked with aging and disability resource centers and criminal justice organizations all around the country, teaching them the NIATx model. And I think that's one of the unique things about this is that I came out of a background working in healthcare for a hospital system, and the hospitals had their quality improvement programs that almost all of them were engaged in. But I don't think too many community health organizations like substance abuse treatment providers or mental health organizations or even public health departments had a quality improvement program that they could wrap their hands around. And I think NIATx provided that opportunity for them as we've seen it just grow exponentially.